Webinar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for a HealthyU Webinar Series. Today's topic is identifying vertebrae fractures. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We'll answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Bilal. Upon earning his medical degree from the School of Medicine at Boston University, Dr. Bilal completed a residency in diagnostic radiology at Long Island Jewish Medical Center in New Hyde Park, New York. During his residency, he was a junior and senior chief resident. He concluded his training with a fellowship in vascular and interventional radiology at Long Island Jewish Medical Center in 2004. Dr. Bilal is certified by the American Board of Diagnostic Radiology and specializes in all aspects of diagnostic and interventional radiology with a particular expertise on oncology, interventions, women's health, and spine intervention. All right, Dr. Bilal, let me get your presentation up and then we'll get you going.
Okay. Well, good afternoon, everybody, and thank you for the opportunity to present this topic. So today I'm going to be talking a little bit about the early diagnosis and management of osteoporotic vertebral compression fractures and sacral insufficiency fractures. The two of these entities are somewhat related, mostly because of patients who have underlying osteoporosis. Next slide. So when it comes to identifying vertebral fractures, or what can be known as compression fractures, we know that almost 2/3 of patients can go undiagnosed without having been identified for a fracture, and can make that determination very difficult when it comes to evaluating them for their symptoms. Many times these fractures can also be asymptomatic. Someone who suffers from osteoporosis may not realize that they have had a compression fracture, a subtle one, and may not have any sequela or any presentation with pain. The pain can range from being very mild and being misdiagnosed or misinterpreted as mild back pain, or it could be very severe and acute onset, sudden, sharp, consistently unchanging in its location, and will eventually gradually disappear over several weeks. A compression fracture on its own, generally speaking, takes anywhere between 12 to 16 weeks to heal. So something that may linger for quite some time may raise the suspicion for a vertebral fracture. It's important to know how to diagnose these fractures and to understand that when we order certain images, that not only do we start with just x-rays in the AP view, which is sort of looking at someone in the mirror, but also consider it from the side view, which is called the lateral spine x-ray. And many times we would also want to get follow-up imaging because the initial set of pictures may or may not illustrate the fracture right away. Next slide. When it comes to osteoporosis, just to give an idea of what osteoporosis is. So basically, this is a skeletal condition where the underlying bone is reduced in its density. And so because it's reduced in its density, it basically does not have the same mechanics to withhold or maintain weight upon it. And so its integrity and its strength is compromised. And so you can see on the picture here on the left side, this is what a normal bone could look like on a magnified view inside the bone. Excuse me, but a osteoporotic bone, these bony structures are thinned out, weakened, have less calcium in them, and therefore are susceptible to fracturing either due to an injury or spontaneously. Next slide. Now, these are two pictures that are illustrated here side by side. On your left side, you have a CAT scan view of someone's spine, looking at them from the side. And this is a patient who has somewhat normal bone density. On your right side of the screen, you have a patient who's osteoporotic, and there's significantly less density in the bone. And therefore, you can see that the vertebral bodies are thinner, which is sort of the block of bones that you're seeing in the middle there. And also, there is a loss of the height of one of these bones in comparison to the rest. And if you count from the top of the screen on your right-hand side, 1, 2, 3, 4, number 4 and number 5, both of them show that the top portion of the bone is somewhat compressed. And this is, just getting my pointer here. So this would be illustrated right in these two bones right here. Okay. So those are what we call compression fractures. So the height of the bone is decreased, and there's sometimes these fractures can involve the top portion of the bone. It can also involve the bottom portion of the bone, or it can involve both the top and the bottom of the bone to make it look like that. Next slide. I gotta erase this. Okay, let's get rid of this. Okay. So we know that the location of fractures do matter. Our spine is one curvilinear structure, kind of like an S shape. And because of the S shape, the upper part of our thoracic spine is considered a kyphosis, in other words, leaning forward. And the lower part of our spine, which is the lumbar spine, is a lordosis in the reverse direction. And there are certain points in here which are susceptible to higher risk for fractures, just because they're almost like a joint. Because of the bending mechanisms and the weight bearing that we have in our back, these can be susceptible. So in the thoracic spine, as highlighted there in yellow, in the upper portion at around T7, T8, and at the thoracolumbar junction, thoracic number 12 and lumbar number 1. These are sort of two areas where the curvature is more pronounced, and they bear a greater loading pressure or stress, especially particularly when one is either leaning forward or leaning backwards. And the thoracolumbar junction is where the upper part of the spine, which is somewhat more rigid as compared to the lower part of the spine at the lumbar area. And so that's another junction point that also can act as a fulcrum where more stress is applied at that from a mechanical point of view. And so what happens is that the spine, which has low bone density, is now susceptible to these increased areas of stress. And so the incidence of compression fractures at these points is a little bit higher. Next slide. So what's important to recognize is that if a patient has one fracture, an initial fracture, what does that do for their future risks, especially if they continue to remain osteoporotic? And what we know from literature and from data collected over studying these, we know that the patient has a 5-fold risk of an increased fracture for having a second fracture, especially when they have it the first time. And when you have it the second time, you now have a 12-fold risk. But if you have more than 2 fractures and you have low bone density, this exponentially rises to almost 75% fold. So it's really important to recognize the fact that if a patient has an initial compression fracture due to osteoporosis, that we aggressively manage them either conservatively or through a procedure to make sure that we not only identify the underlying problem, which is usually osteoporosis, making sure that they have resources to address or manage osteoporosis, but then also be able to treat the first fracture so that their fracture future risk reduces as significantly as possible. Next slide. Now, what are the long-term consequences of a fracture? So we know that patients will suffer initially with back pain, and then eventually that may lead to a spinal deformity depending on how much that bone compresses, how much height loss is there in that bone. And if there's somebody who has fractures within their thoracic spine or their upper spine, because of the pain, because of the back spasms, they're unable to take deep breaths in. And so that can also lead to decreased lung capacity, which then leads to impaired function, inability to ambulate, inability to tolerate long distances, inability to do things that they perhaps could not do before. And so with all of that combined, being unable to sleep, and they now become increasingly at risk for further fractures. They're not ambulating well. And sometimes because they can't ambulate well, they become a risk for additional fractures. Their walking is altered, their mechanics is altered. And so there's a downward spiraling effect that starts to happen for patients, who have multiple compression fractures and have a chronic issue. What I didn't mention in here is the fact that a lot of these patients also can suffer from depression eventually. There are many patients who are independently living, but then now become dependent either on using a cane or an assistive device, a walker. Perhaps they didn't have family living with them before, or they need to move in with family. And so somebody's independent life now becomes a dependent life. And that can really increase the psychological impact that this can have on the patient's recovery. Next slide. So how do we manage compression fractures, or how do we evaluate? So usually when we think about compression fractures and we have a suspicion for it, we usually initially start off with basic x-rays. And here we have on the top row, there are x-ray views of the bone. And what I've done is I've highlighted what looks on your right-hand side of the screen going down the list. These are images from the sacrum or the pelvis, which is another common area to experience fractures. And on the left-hand column are images of the spine looking at vertebral fractures. So here on the x-ray, this is a lateral view, you can see here that this is the compression here of the vertebral body, looking at it from the side view. Similarly here on a CAT scan view, you can appreciate the same thing. On the MRI view, similarly, we can appreciate it. And this is a bone scan, which is a nuclear medicine scan used to demonstrate bone activity and recovery and healing. And so sometimes a patient may not be able to tolerate an MRI, or perhaps they can't have a CAT scan done for one reason or another. So we may use a bone scan to help illustrate the nature. So what becomes really important is that we tend to use MRIs and bone scans to help us evaluate fractures that are either new or old or active. A CAT scan may demonstrate the fracture abnormality being there, same thing with an x-ray. But what it may not tell me is how old is this fracture. And if I don't have any previous films to compare it to, that can make that really challenging to understand the timeline of when did this occur and whether or not it's quote unquote active. The MRI gives us a sense of when something is relatively new based on the signal in the bone, and same thing with the bone scan. Based on the cellular activity in the bone, we can get an idea that this is relatively new, or if it's an old fracture, and whether or not that patient may benefit from management procedurally. On your right-hand side of the screen, these are pictures of the sacrum. So I just want to illustrate here, same thing. You can see activity in the sacrum, kind of looks like a Honda sign, as we call it in radiology. On MRI, same thing. In the bone, we can look for these increased signals inside the bone, which is illustrated by this brightness in the center of the box. That's called edema, which is bone bruising and has fluid in it, so it shows up. And that's kind of how we are able to tell if something is relatively new or old. If this was an old fracture, this brightness would not be in there, and that would tell us that this is something old. Just going to erase all of this so we can move on to the next slide. Next slide, thank you. All right, so how do we manage these compression fractures? And so there's a non-surgical approach, and then there's a procedural approach. So on the non-surgical side, most of the time we talk about pain management. What can we do to alleviate the discomfort? Muscle spasm is very often common because our ligaments and our muscles that surround our back start to tighten up to help reinforce the alignment. And that's our own body's natural mechanism to do that. And so having muscle relaxants to help alleviate the spasms is helpful. Physical rehabilitation to, again, soften up the muscles, help us with our alignment, and also promote core strengthening that can also facilitate our rehab in our back alignment. Orthotic devices such as a back brace is also many times initially recommended. Now, for those who may have seen it or have experienced it, these can be soft or hard shelled. And if it's a soft brace, then they tend to be more like a corset and can be applied and taken off very easily. And oftentimes they're a lot more comfortable. But if you have a hard shell, that could be pretty challenging to wear all the time. And so compliance becomes an issue, comfort becomes an issue, and being able to use it and maintain it becomes an issue. And so many times these hard shell braces are kind of fitted to the patient, but they could be quite difficult to keep on, depending on the patient and what their back deformity may look like, curvature. And then, like as I mentioned before, you want to make sure that we are managing their osteoporosis, that we're able to get them to medical management. And there are a host of agents that are out there. Not one is ideal for everybody. So your referring doctor, your primary care doctor, your endocrinologist or rheumatologist, these are all specialists who may see you for managing bone density and will evaluate to see which of these agents may be potentially possible for you to have and be a candidate of. On the procedural side, we have the least invasive option technically, which is called a vertebralplasty, followed by what's called a kyphoplasty or vertebral augmentation. And then we also have other forms of this called radiofrequency targeted vertebral augmentation, and then a true surgical procedure, which is essentially fusion and reconstruction. Now, vertebralplasty in of itself is a procedure where we can place needles into the bone and basically inject cement directly into the bone. And augmentation, the second one, kyphoplasty, is basically where we place needles into the bone, create a pocket or use a balloon or an instrument to create a space, and then fill the bone with cement, which hardens right away. And then the other one, or radiofrequency vertebral augmentation, is basically cement that goes in heated by radiofrequency and then hardens. And then, of course, you have the surgical, which is basically an actual procedure performed either by spine surgeons, orthopedic spine, or neurosurgical spine. And that's actually true spinal surgery with screws and things of that like to help stabilize the back. Next slide. So when it comes to vertebral augmentation, which is something that we do here in interventional radiology quite often, these are procedures that we do under X-ray or CAT scan guided. We consider these to be minimally invasive, typically going in from one side of the bone or both sides of the bone. And on the outside, usually all you'll see is these 1 centimeter like incisions. Each fracture level takes roughly about 15 minutes to treat. And we could do these under local anesthetics or using conscious sedation, which is light twilight medication. But if we have to, we're also able to do these with general anesthesia. And sometimes patients are not candidates to have general anesthesia from maybe perhaps another specialty, or if there's another procedure being involved. So interventional radiology can be very helpful that way to illustrate the potential to perform these procedures not requiring sedation or heavy sedation needs. And we do these typically as an ambulatory procedure, and our patients are typically discharged roughly about 1 hour following the procedure. Next slide. So here, this is an example of a patient who has a vertebral compression fracture. So this is a patient who initially had a very subtle fracture here on the top of this bone. And over time, this bone developed another fracture and progressed. And you can see how the height of this bone has dropped from the roof down. The bone, this is an MRI view. So if over here in the center of the film is brightness, which is fluid inside the spinal canal, and this is the spinal cord here. This bright signal inside the bone is the marrow edema that we refer to as the signal of inflammation. And that tells us that this is a relatively new fracture or an acute fracture. And because of the inflammation, this is going to cause back pain for the patients. And we know that this is then potentially a candidate to have this type of procedure done. On the bottom, these are images from a bilateral kyphoplasty procedure. And by bilateral, what we mean is there are needles that have been inserted from both sides of the bone. We enter in through the what's called the pedicle, which is the back portion of the bone. And once we are there, these balloons are blown up to create a small pocket. And this pocket may also allow us to raise the bone or correct the deformity in the bone, depending on the fracture morphology. And then under X-ray, we inject this with a bone cement that looks initially like toothpaste consistency or dough consistency. And then this will eventually harden within a few minutes and will be as hard as bone. And based on what is being used inside the cement, this will also allow for bone to grow around it or into it to help reinforce that bone. Next slide. Now, this is a patient of mine who initially in 2011, I'm just showing two pictures of her spine. And she was very osteoporotic initially and had one fracture. And unfortunately, because of the extent of her osteoporosis, she was basically a constant presentation with back pain. She knew exactly when she felt it. She knew exactly when it occurred. Most patients say that they know exactly when it feels like bone pain and they will present. And so here we were able to sustain her quality of life over a progressive number of years by periodically treating her over and over again and helping her to stay independent, be functional, enjoy time with her grandchildren, and avoid being kept in the hospitals on chronic pain medications and things of that sort. So we can really make a big impact on that. Next slide. Similarly, we had another patient also who suffered multiple back fractures in their thoracic spine. And that patient also had COPD and difficulty breathing and, really made an impact on her quality of life. And same thing, eventually treated multiple levels over a period of years while we were still trying to actively maintain her osteoporosis and manage it. But again, you could continue to make a profound impact on these patients' lives through these minimal procedures that we can offer here in interventional radiology. Last slide. So in summary, fractures of the spine and the sacrum are fairly common, and they can present as a major source of morbidity, illness, hospitalizations. And interventional radiology, which is my specialty, we can play a pivotal role in not only to help diagnose them, work them up, order the appropriate imaging, but then also offer ways to minimally invasively treat them, particularly for those that are symptomatic and maybe at risk for ongoing fractures, and allow us to stabilize the bone, reduce the amount of time for them to have pain control, taking something that could last weeks and reduce it to days. And then also hopefully be able to align them and identify them so that they can seek management for osteoporosis. The goal obviously being that we want to ultimately improve the patient's quality of life and reduce any other mortality that might, or morbidity rather, that might be associated with compression fractures as a whole. And that's my last slide. Again, thank you for the opportunity to present this topic.
Thank you again, Dr. Bilal. If anybody has any questions, you can put them in the Q&A feature at the bottom of the screen. All your questions will remain anonymous to protect your privacy. We'll give it a few moments here, Dr. Bilal.
Sure.
If anybody has any questions.
No problem.
All right, so it doesn't look like anybody has any questions. For everybody on, if you think of a, oh, I apologize, we have a question now. Dr. Bilal, are you able to see the Q&A feature?
Yes, I do. So the
Okay.
question being asked is, are these fractures due to a fall? So the answer is partially yes. Trauma is usually the first thing that we inquire about. Did the patient physically fall? Sometimes they've just sneezed very hard. We've seen patients experience a fracture lifting certain objects. So trauma doesn't always have to be involved. These can be spontaneous and unrelated to trauma.
All right, so it looks like that's the only question that we have. If anybody can think of any other questions, you can email them to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you can please complete the survey, your feedback is extremely important to us and helps us plan our future programs. Thank you everybody for joining today. If you're interested in seeing previous HealthyU webinars, you can see them at www.matherhospital.org/HealthyU. Thank you all again, and thank you again for your presentation, Dr. Bilal.
Thank you, everyone. Have a great day.